gonna hi. It was very hot, indeed. The mic is clearly on, and we are going to get started. May I ask people to please take your seats? This is the first personal in-person gathering in a long time, and I know there's a lot of reconnecting and hugs that have gone by the wayside, and we all want to come together and see each other, and what a very special occasion. Well, it's an absolute pleasure to see you in person and to have this time together to celebrate and to honor a hero of preventive medicine, Dr. Daniel S. Blumenthal, the past president of the American College of Preventive Medicine. It's lovely to see so many fans of Dr. Blumenthal's in the room, and I know hundreds of you are joining virtually, live, from your homes, your offices, wherever you may be in whatever time zone that you're living in right now. In this room with us tonight are so many wonderful leaders of prevention, of preventive medicine, and of course, health equity, the topic for our time tonight. Now we have found our seats in the room. We've secured good Wi-Fi at home or wherever you are. My name is Donna Grande. I'm the CEO of the American College of Preventive Medicine, and welcome. In 2019, before we found ourselves in this pandemic, we lost a beloved Dr. Blumenthal. Many of us were stunned by the news and saddened by his passing. The Morehouse School of Medicine did a beautiful memorial for him, and I had the distinct honor of being able to represent ACPM and pay our respects on behalf of the college. It was amazing to speak to so many friends, family members, and to pay my respects to those that loved him so well. But my time with Dr. Blumenthal was very limited, only in my tenure here at the college. And during that time, he touched me deeply, going on site visits to the Centers for Disease Control and coming up to the DC office to see our staff and to do a lunch and learn, to share about his amazing career. Such an impressive man with a big heart, a beautiful smile, and clearly an amazing legacy. Knowing his love of the American College of Preventive Medicine, we also wanted to honor his legacy. And to share a bit of that evolution, we've asked Dr. Stephanie Zaza, our immediate past president of the college, the one who identified the lecture, the award, and identified our first inaugural awardee. Although she needs no introduction, I think it's appropriate to share that Dr. Zaza had a distinguished career at the Centers for Disease Control and Prevention. She has led so many numerous programs, projects, preparedness and response efforts before her retirement after 25 years of distinguished service. She made the decision to uproot from all of her friends and familiarity of Atlanta and moved to the mountains of Colorado to actually enjoy the mountains in retirement. Little did she know, stepping into the president's role of the American College of Preventive Medicine in the midst of a pandemic would become a full-time job. She stayed apprised of all the science, the daily changes, everything we were seeing in the policies, the protests, the needs, the data collection, all of the public health shortfalls, and the criticisms of her beloved CDC, and every other nuance that was impacting our country in the midst of a pandemic. Her term ended this past May, and so it's truly a delight to invite her back to the college to share all that she knows and loves and is passionate about. So Dr. Zaza, without further ado.
Thank you. It's really wonderful to leave my little bubble of rural Colorado and see so many people. It's a little overwhelming, to be honest. In May of 2017, Dr. Daniel S. Blumenthal presided over the Preventive Medicine Conference as ACPM's president and chair of the board. Dr. Blumenthal used that platform to select keynote and plenary speakers who shared his academic and programmatic expertise in the social determinants of health. At the end of that conference, I began my tenure as president-elect, then president of ACPM, and during those 4 years, the breadth and importance of those presentations became a touchstone for me. 2 years later, when I learned of Dan's death, I knew immediately that ACPM could only acknowledge his incredible career and legacy by continuing to educate our profession, colleagues throughout the health and medicine enterprise, and decision makers in every sector of society about the relationship between social justice and health. Thus, the idea for this annual Daniel S. Blumenthal Lectureship to address structural racism, health equity, and social justice was born. In preparing for today's event, I heard from several of our members who expressed gratitude to ACPM for honoring Dan this way. As I was looking through the various notes, I realized that Dan's passion, his kindness, and his attention affected every generation of our membership. Dr. Jacob Adams paid Dan one of the highest compliments possible. He wrote, "I only knew Dan a little, but was touched by his commitment to teaching and mentoring, the time he took to learn about people, his quiet egolessness. He was someone I hoped I could become like, a real mensch." Dan and I shared time on the ACPM board with Dr. Olubenga Obasanjo, and like Jacob, he was touched by Dan's ability to connect on a personal level and impressed by Dan's knowledge of the politics and history of Benga's country of birth, Nigeria, and of Africa as a whole. Benga also wrote of Dan's ongoing mentorship and encouragement of him to train the future leaders of preventive medicine. Our American Journal of Preventive Medicine editor-in-chief, Dr. Matt Bolton, was unable to be with us here in person today, but he wrote a lovely note about the day Dan interviewed him for the editor's position. After apparently grilling him for quite a while with tough questions, Dan later expressed his unqualified support for Matt's selection, and over many years for the journal and Matt's leadership of it. A mentor, a visionary, a connector, a patient man who knew that change comes slowly, an optimist who knew that change is indeed possible. In these ways, Dan touched our lives and guided our profession. Dan's death in 2019 preceded the world-changing events of COVID, the murder of George Floyd, and the emergence of a heightened focus on social justice and its relationship to health. Though I profoundly missed having his counsel, I hope that Dan would have been proud of the steps ACPM took in response to these events. With guidance from Aletha Maybank and others, we looked inward. What in our history required truth-telling, reconciliation, and remedy? We also looked outward. What is our role in addressing social injustice in health? This lectureship is one important piece of our ongoing work to push our quest for health as far upstream as possible. In reaching for that goal, today's event looks back, considers what we are doing today, and looks to the future. We will hear more about Dan from two people who knew him best. We will award the first annual Daniel S. Blumenthal Lectureship Award and hear from our awardee about some of the most critical ongoing work for social justice today. And we will close with a panel of distinguished experts to help us continue to connect the dots between health crises of today and tomorrow and the social justice movements that will help us address them. Our first two speakers today are Dr. Marjorie Speers and Dr. David Satcher. Dr. Marjorie Speers served as Deputy Associate Director for Science at the Centers for Disease Control and Prevention, the Executive Director of the National Bioethics Advisory Commission, President and CEO of the Association for the Accreditation of Human Research Protection Programs, and the Executive Director of Clinical Research Pathways, a nonprofit that worked to increase minority representation in clinical trials. She is also the widow of Dr. Dan Blumenthal and shared his passion for science, representation, and social justice. Dr. David Satcher is the former director of CDC, Surgeon General of the United States, and Assistant Secretary for Health in the Department of Health and Human Services. He served as the president and dean of Morehouse School of Medicine, where he worked together with Dr. Blumenthal to create and oversee programs in community health and health leadership. Please join me in welcoming Dr. Speers and Dr. Satcher to say a few words about our friend and colleague, Dr. Dan Blumenthal.
Well, welcome, I guess. I'll say welcome. I'm very glad to be here to say a few words about Dan and ACPM. First, I'll begin by thanking Donna, Grande, and the staff and the Board of Regents for going forward with this lectureship. I was aware, going really back 2 years to his death, that ACPM wanted to do something, and to be able to pull it off this quickly after being in this pandemic, I think is really great. And it means a lot to me, to his children, and to our family. So thank you for this. I want to actually, I'm going to go through just a very brief history, but it goes back, it starts in 1969 when Dan was trying to avoid the Vietnam War, and so I apologize to any military in the room for that, but he worked very hard not to be in the war. And so what he did is he spent a year in VISTA. He was the first physician to be part of VISTA, and he was assigned to Marianna, Arkansas. And he worked in several black communities in the area and really was quite touched by the health status of individuals in that area, but more so by the abject poverty that people lived in that was found acceptable at that time for these individuals with really no access to health care. And that's really what started his interest in social justice, his work in communities, particularly communities of minorities, and his desire to make a difference and to ask the question of why do these circumstances exist. This is why he became interested in social determinants of health. After VISTA, he went to CDC as an EIS officer, and when that term ended, he went to Emory, and he was on the faculty in pediatrics at Emory when a new medical school was starting in Atlanta, Morehouse School of Medicine. And he was very interested in that school and decided that that is really where he wanted to work. And so I think that when you think about Dan and the man that I knew for 26 years, this was a man who was driven by his mission, and his mission was to improve the health of the underserved, of minority populations. And his approach to doing that was really twofold: to work in the community with individuals and to train healthcare professionals, primarily physicians, and he found his home to do that at Morehouse School of Medicine. So he was very fortunate to not only have a career that he absolutely loved, and I can tell you, till the day he died, because he died suddenly and unexpectedly, and he was working that day. So he always worked, as I would say, right, David? But he found his home as well, and so he always felt a great debt to Morehouse for being his home. So it means a lot, I think, to have this award, because what Dan did when he came to work for as a volunteer for ACPM is he wanted to take what he had been doing at Morehouse and in training physicians at Morehouse and really look at that on a national level, which he could do through ACPM. He wanted to continue to move preventive medicine in the direction of social determinants, racial equity, social justice. And I think it was really a good match for him to be working with ACPM. And so I'm grateful that he was able to do that and had the time he did with ACPM. And I'll just close by again saying thank you for this award, because I do think he would be quite pleased about it, because it's at least an annual reminder every year, that there's going to be a focus on social justice. And then to finally end by saying to Dr. Satcher, David, who I worked with and is a friend of mine, I'm so glad you had the good sense to hire Dan in 1980 and bring him full-time on staff at Morehouse School of Medicine. Okay.
Thank you very much, Marjorie. I decided to leave my papers behind and just tell you that Dan Blumenthal was an amazing human being. I had an opportunity to work very closely with him during good times and bad, and I will always appreciate Dan for his integrity, for his caring, and I think people in the community saw that. Many institutions have difficulty working with communities for various reasons, but I think Dan was able to earn the trust of people in the community so that when he said something, they believed it, they listened. I say that now because, as you can imagine, for the last 2 years, I've been quite involved in trying to bridge the gap between community and government and public health when it comes to the vaccine issue and things like that. And I must say that Dan did a great job at that. He was trusted for good reasons. He was true to his word. If he said he was going to do something, he did it. And that kind of integrity showed throughout the community. Now, I'll tell you a little story. When I got to Morehouse, and you remember Lou Sullivan was the founding president, and I didn't have anything to really work with at first. None of us did. We were all building from scratch. And one day I got a call from Dan, who was at Emory at the time, and he said, I just read this article about you and what you're going to try to do at Morehouse. I'd like to talk with you about that. So I invited him to breakfast at Pasca's. I don't know how many of you know about Pasca's, but I'll tell you just a little bit about it. When I was a student at Morehouse between 1959 and 63, we were involved in the student movement. Many of us went to jail. Some of us went to prison during that time just because we tried to eat at restaurants. And it was during that time that Pasca's, the only fully owned black restaurant in the city, became so popular. Martin Luther King Jr. had his meetings there over breakfast. And those of us who went to jail looked forward to getting out of jail and coming to Pasca's to eat because we could eat free if we'd been in jail. It was, so it was quite an experience. So I invited Dan to join me for breakfast at Pasca's, and he agreed. And I noticed that Dan was really enjoying the grits. So I said, Dan, you like grits? He said, well, I never had them before, but these are great. So from that time on, I would tell people the way I recruited Dan to Morehouse was the grits at Pasca's. And at first he would sort of deny, but then later on he decided, what the heck, he's not going to stop saying it. So he started saying it was the grits and not me that recruited him to Morehouse. But let me just say that I've worked with a lot of people in my days. I've been around a long time. But Dan was special. He really was. He was, regardless of race, creed, or color, Dan had a way of endearing the trust of people. There was something about him that led people to trust him, and mainly if they watched him long enough and they saw that he was true to his word, that what he said he was going to do, he did it, and that he respected. This is so critical as I struggle now with young people in medicine, the kind of respect that he showed for the people in the community, that people in the community trusted Dan because he respected them and he treated them with respect. So Dan was special in that sense, and he was a great scientist, make no mistake about it. You hear a lot of stories about the smallpox eradication, right? Dan never said anything about the role that he played in that. That was Dan. You know, he didn't boast about what he had done or what he had been involved in, but he too was quite involved in the eradication of smallpox. So we need more people like Dan Blumenthal. We need the integrity that Dan represented. And of course, we need his skills in teaching and communicating generally, and the respect that he showed for other people. I wish you had been there at times when people from the community would come to the school looking for Dan. And if there was any question about it, he would tell you what Dan told them, and that they were there because they were following up on what he said. Then, as far as I know, he never stopped seeing patients because he loved seeing patients. And that seems to be a common trait among many people in preventive medicine and public health. They still want to see patients. And Dan was certainly that way, and I appreciated that about Dan. Now, Dan and I were on separate tracks for at least 12 years. And I won't go into details, but I think many of you remember when the New York Times had the front page story saying that Majorie was going to close. So I was one of the people that I'm sure was sought after to take the role of president of Majorie. And when I went to Morehouse, I had no intention of leaving anytime soon. But that changed, and I decided that I could make a contribution to the future of Majorie, and that was something worth doing. This institution that had graduated the majority of black physicians and dentists deserved to survive, and it deserved to be supported. So what happened, I left Morehouse. Dan took over as chair, and both institutions benefited significantly. And Dan and I stayed in touch over the years. I will always appreciate him and what he stood for, and I appreciate Marjorie. Not only do I appreciate Dan, a lot of other people. Now, when my children were very young, and we had a party at the house, and a lot of people came, but it was Dan who brought his guitar. So I didn't even know Dan was a musician until that night, and he brought his guitar and played it, and people sang. That's the part of him that a lot of people didn't know, that he was entertaining, he was funny, but the bottom line is he cared deeply about people. Thank you.
Thank you both so much for those wonderful comments. I'd like to now introduce and announce the first annual Daniel S. Blumenthal Lectureship Award and introduce our lecturer awardee. Dr. Marcella Nunez Smith is the Associate Dean for Health Equity Research at the Yale School of Medicine, where her work focuses on health inequities in the Caribbean and chronic disease disparities. She led the COVID transition team for the incoming Biden administration and was then appointed to serve as the co-chair of President Biden's COVID-19 Advisory Board and Health Equity Task Force. Just this week, Dr. Nunez Smith was announced as an electee for this year's class of entrance into the National Academy of Medicine. As our inaugural Blumenthal lecturer and awardee, ACPM recognizes Dr. Nunez Smith's outstanding scholarship on health equity, her active voice for social justice, and her leadership of the President's COVID Health Equity Task Force during this tumultuous period in our nation's history. The task force's report makes numerous recommendations to address disparities in COVID outcomes, and even more importantly, the task force makes specific recommendations to move the work into upstream areas such as the economy, housing, and education to achieve specific health goals. Dr. Nunez Smith is also a practicing physician along with her other duties. And so, in the midst of the pandemic, she has made the often challenging decision to not travel and to maintain full focus on her own well-being and that of her colleagues, staff, and patients. She was extremely excited to receive this award, and so joins us now from her home in Connecticut. Please join me in congratulating and welcoming Dr. Marcella Nunez Smith as our first Blumenthal lecturer. And we'll be presenting her with this beautiful piece of art as our awardee as well. So please, we'll watch on the screen.
Hello, everyone. I'm thrilled to be with you today. I'm Dr. Marcella Nunez Smith, Senior Advisor to the White House COVID-19 Response Team and Chair of the Presidential COVID-19 Health Equity Task Force. I'm also a practicing internal medicine physician and founding director of the Yale School of Medicine Equity Research and Innovation Center. And our mission there is to generate actionable research that promotes health across populations and equity within our healthcare system. And I am deeply, deeply honored to be the inaugural recipient of the Daniel S. Blumenthal Award. And I'm grateful for the invitation by you, the American College of Preventive Medicine, to share a few remarks with you today. ACPM has been just a tremendous advocate, a deep supporter of important work, critical work on health equity, informatics, the social determinants and drivers of health, and racism in healthcare, including Equity Matters, and that, along with the Council for Medical Specialty Societies and the ACGME, is embarking on a year-long program to address structural racism in medical schools and across the field. This effort, Equity Matters, that is fundamental to ensuring a representative and transformational workforce, and is another key step towards achieving health justice and equity. And so with that, I appreciate this opportunity to be in discussion about the COVID-19 pandemic, about the ways in which it has brought extant health disparities into sharp relief, and to share some of the work the Biden-Harris administration is doing to address this public health crisis. As this global pandemic continues to shape our lives, we simply can no longer ignore the way that social realities define levels of access to care, to resources, and to opportunities to optimize health. We cannot understand the scope, the scale of the tragedy and the toll of the pandemic without looking towards its severe, its persistent, unequal burden on communities of color and other marginalized groups. We look at the mortality rate for Pacific Islanders, those who are Latinx, Indigenous, Black Americans. That COVID-19 death rate double or more that of whites and some subgroups of Asian Americans. And it extends that burden and its unequal leveling on marginalized communities when we think about the economic consequences of the pandemics. These inequities are not emerging for the first time. They are deeply ingrained in our political, economic, and healthcare institutions. Many, and I know many of you, have been aware of these inequities for some time. This year is different. It's been a moment of renewed energy, a sense of restored mission. And we see this not only in healthcare, but quite frankly, in all aspects of our society. We've had a collective witnessing, and it is up to us now to meet this moment. We cannot eliminate health inequities without broadening our view, considering these society-wide elements that shape health. This includes economic pressures, political realities, our social fabric, and we have to make it explicit that individuals exist in these differential contexts. This moment has forced us to reckon with our priorities, our values as a nation. And if we value the right to health and well-being for all, we have to rethink the way we've structured our approach to health. And so to meet this moment, the Biden-Harris administration centers equity in its response. And also, as we set the stage for health equity now in the future, thinking about recovery and resilience moving forward. I'll talk for a moment about the vaccination campaign. Recognizing the need, obviously, this work to center in equity, to prioritize access. And in the early weeks of the Biden-Harris administration, we set up several direct federal vaccine allocation programs, partnering with community health centers, retail pharmacies, community vaccination centers, mobile vaccination sites, all of those programs designed with key equity-oriented features and metrics in mind. And they have been key and successful in reaching people of color. We set out to increase the number of vaccinators, funding cities, towns, and states so they could test and vaccinate their communities. We partnered and continue to with community and faith-based organizations so everyone across the country could go to a trusted source to get the most accurate information. And that for some is a house of worship. For others, it's a medical practice or a local community center, a barbershop, a beauty salon, building vaccine confidence and increasing access at every turn. Then we work to address those structural barriers to access. Vaccination venue location matters, but thinking about things like transportation, access to paid time off, ensuring walk-up, no appointment necessary slots, providing childcare, knowing always the need for outreach and engagement and partnership to be hyper-local, refocusing efforts and resources on and in communities. Sending COVID-19 surge response teams to support local outbreaks across the country, with these teams offering testing, expanding detection of the virus, medications to help treat those who have been infected, federal personnel to fill gaps in staffing, technical experts to help investigate outbreaks. And knowing also that we must recognize the endemic nature of the pandemic. And so everywhere we show up to talk about COVID-19, also lifting up, listening to the realities for people on the ground, community violence, housing instability, difficulty accessing nutrition, being sure that we're talking about the whole of person in every step. And so still, yes, in this near term, talking about vaccinations, but prioritizing the equitable distribution of all the COVID-19 resources. People need to be safe, to stay protected. That includes PPE, masks remain essential, but testing, access to therapies. And of course, when it comes to vaccines and vaccinations, we will continue to make sure that vaccination is easy, it's convenient, making sure everyone knows vaccination is free, that there are no out-of-pocket costs, that government-issued ID is not required, documentation status does not matter, data privacy is always maintained. So where we are today in the pandemic, we're seeing the results of all of our combined collective efforts. So much of this lift has been done by you, by providers, by epidemiologists, health agencies, health officers, alongside community leaders and nonprofit organizations and the private sector. I always want to take us back to data, and according to Kaiser Family Foundation, similar shares of adults now report being vaccinated across racial and ethnic groups. In a report published at the end of September, the CDC's National Immunization Survey of 19,000 adults by phone found that 73% of Black adults, 76% of white adults, and 78% of Hispanic adults had now been vaccinated. And recently, Pew Research Center, they surveyed over 10,000 adults online and found that 70% of Black adults, 72% of white adults, and 76% of Hispanic adults had received similarly at least one dose of a vaccine. So this increase in vaccination rates, the decrease in vaccination inequity, would not have been possible without collaboration and intentionality at every level of society. And given ACPM's deep history of passion for and understanding of the importance of vaccination, Dr. Jonah Salk was one of ACPM's earliest members. So I know you all share a deep, deep appreciation for our combined success in this area. There's absolutely more work to do, but notable, and vaccines are such a key tool in our toolbox as we all move to get to the other side of the pandemic. But I do want to spend a couple of minutes talking with you about some of the other work I've been honored to be part of in this past year. And I've been chairing the Presidential COVID-19 Health Equity Task Force. And that group, phenomenal set of individuals and champions and advocates working to develop recommendations at the charge of the president to mitigate the health inequities exacerbated by COVID-19 and to prevent these inequities in the future. At the end of September, we had our 7th public-facing meeting and voted on the final recommendations that we'll deliver to the president. Since we were formed by executive order and the president's first full day in office, the task force has generated more than 300 recommendations. And the Biden-Harris administration has already taken steps that address over 60% of these through a host of executive orders, memoranda, and agency-wide initiatives aimed at ensuring an equitable response to the pandemic. So the refined recommendations, they will be synthesized into the task force final report and delivered to the White House COVID-19 response coordinator. The COVID-19 Health Equity Task Force has worked tirelessly to present a vision for change that will help improve equity, we believe, today and for years to come. And one of our charges is data. And so a substantial number of the recommendations are focused on just that. I don't have to tell you, but COVID-19 exposed fundamental flaws in our data collection systems, undermining our ability to understand the true scope and impact of COVID-19 on marginalized communities, delaying along the way key interventions and real-time response. Programs that rolled out in response to COVID-19 took a long time to develop and launch. The targeted direction of resources has been stymied often by the lack of disaggregated or standardized data collection and reporting. We have an outdated data infrastructure, we have outdated data choices, and they all initially fell short on informing an equitable and real-time pandemic response. And the limited data that we did have provided an insufficient picture of what was happening in high-risk communities. For so many people, they are invisible in the data, leaving policymakers ill-equipped to direct those necessary resources where they are needed most. I was speaking to many of you, members of ACPM who work directly in clinical informatics. You share this understanding, you have this knowledge, the importance of robust and accurate data to ensure delivery of an equitable and timely response. So we are just very encouraged to see movement in that direction. So the task force has developed a set of recommendations to address these data shortfalls, other data challenges that must be tackled in order to better prepare and respond to future pandemics. To make equity actionable, we must establish a data ecosystem that promotes equity-driven decision-making. So you'll see things in the recommendations like the federal government should fund an equity-centered approach to data collection, including ensuring sufficient funding to collect data, remove administrative barriers, to approve and support all agencies to comply with collection and reporting of expanded health equity data elements based on standard, disaggregated socio-demographic data and health equity metrics to achieve outcomes. Or federal departments should strengthen collaboration with community-based organizations by providing robust funding for and to community-based organizations to celebrate and build cultural identity, to prevent mental illness and help address mental health impacts of the pandemic. And those are just a couple examples. But know that from the beginning, the Biden-Harris administration committed to a COVID-19 response strategy that would be fair, equitable, and efficient, and committed to deep partnership all across the country. There is no other way. Partnership is absolutely key to achieving our goal, not just to vaccinate a nation and eradicate this pandemic, but to ensure health justice and equity. Partnership is a broad tent, includes communities, healthcare professionals, advocates, health agencies, policymakers. ACPM is a vital part of the work. With your history of collaborating closely with ASHTO, NACCHO, state and local health departments, ACPM members make critical contributions, serving as chief medical officers, health officers, and in preparedness and response roles within the Centers for Disease Control and Prevention, as well as across other federal agencies. I know together we are committed in this work for a more equitable and just society. And so I just want to thank you for all the extraordinary work that you're doing on health justice, on addressing those social structural drivers of health, and all you're doing to advance health equity in all policies. And let me just again extend my genuine and deep felt gratitude for selection as the recipient of your inaugural Daniel S. Blumenthal Award. It is a profound and humbling honor. And in accepting this award, I want to acknowledge again and elevate all those who work tirelessly in this cause, advocates, policymakers, those across all our health agencies, frontline care providers, community health workers, community champions, and activists. I share this award with all of you. Thank you, and be well.
Wow. Thank you, Dr. Nunez Smith, for your humility, your leadership, and passion for addressing a major issue and an opportunity for our country. We missed having her here, but we know that we will be sending this beautiful award to her, and we're just so grateful that she came to us in this moment. We're going to ask the panelists, the reaction panelists, to come up, and Mark, our AV specialist, is going to get everyone mic'd up on the stage. So we have some incredible dignitaries coming forward. Come on through. Okay. Thank you. Of course. So while they're getting mic'd, I will introduce our distinguished moderator for this reaction panel, a man who really truly needs no introduction whatsoever, but I will say a few remarks to pass the time as the mics are getting loaded up. But Dr. Reed Tuckson is the managing director of Tuckson Health Connections, and he is truly a recognized leader in his field. Dr. Tuckson has been appointed to so many different distinguished leadership roles at the National Institutes of Health, the National Academy of Medicine, numerous federal advisory committees, corporate, nonprofit, and academic boards. He's a graduate of Howard University, not far from here, as well as Georgetown University School of Medicine and the Hospital of the University of Pennsylvania's General and Internal Medicine residency and fellowship programs. He was also a Robert Wood Johnson Foundation clinical scholar, studying at the Wharton School of Business. So his degrees are numerous, his prestige is amazing, and he was one of my former bosses at the American Medical Association, so we have a little bit of history, which is always just a treat. He's an inspirational leader, a mentor of so many individuals. Dr. Georges Benjamin sends his regards as your key mentor as well. And so it looks like everyone is mic'd, so without further ado, I'm going to introduce Dr. Reed Tuckson to introduce this incredibly distinguished panel. As Dr. Satcher indicated, we need more people like Dan. The panelists, from my point of view, each reflect some of the passion, inspiration, and I'm just so thrilled to be able to hear your reactions, so thank you.
Well, thank you so much, Donna. I really appreciate it. Thank you. It's always good to be in the same space with David Satcher. Just terrific. Marcella Nunez Smith is also very special. I've been lucky over the last 18 months to have been single-mindedly dedicated to creating something called the Black Coalition Against COVID. We've been doing more than 20 town halls, reaching probably more than 4 million people. Every time I called Marcella, no matter how challenging her schedule was, she always joined us. She is just, she's the real deal. She walks the walk and talks the talk, and that's important to me. Her comments made me think very carefully about this movement. You know, you see the dog chase the car and you wonder what's going to happen when he catches it. Didn't sort of think about that part, you know. We chased the car and we caught it. This is the moment for equity. This is the moment where everybody is primed, at least half of the country maybe, is primed for this conversation. And the other half is definitely not primed for this conversation. This is an incredibly intense moment in the history of this country. What do we stand for? Is it going to be the human values that that survive, or will it be the naked pursuit of power for its own ends? The jury is out. For us, the challenge is, how do you translate rhetoric into action, rhetoric into reality? This ain't easy. And those of us who have been trying to work this agenda, some of us and people in this room, at least some of us in this room, for 50 years. It's hard to imagine. We were children once. We're old now, many of us. For 50 years, we've been trying to get this agenda on the table, and now it is. And the question is do we have the competence to make it real? Do we have the competence to make it real? We have the energy. We have the desire. We have the intent. Do we have the competence and the ability? And this is really the moment that will put all of our careers and our lives on the line. I think it was very important to hear Marcella talk about broadening our view. There are many other people that now are in the tent with us, people that don't have professional degrees, who are essential to what we do. How good are we at doing that? I think it was very important that she made that kind of point. So we'll come back to some of those things as we go through this discussion. But I am really jazzed up that we have this panel. And let me sort of get us going and begin with our first panelist, Dr. Joshua Sharfstein. And so great, Joshua, for you to be with us. You may not know this, but you are a professor of the practice in health policy and management at the Johns Hopkins Bloomberg School of Public Health, where you also serve as Vice Dean for Public Health Practice and Community Engagement and Director of the Bloomberg American Health Initiative. You're also a former Commissioner of Health for Baltimore. I was lucky enough to be a former Commissioner of Health for Washington, D.C., so I respect that work. You were once Principal Deputy Commissioner of the U.S. FDA and a former Health Secretary for the state of Maryland. In that regard, with what you're doing now in your background, and you listen to Dr. Nunez Smith, in about 5 minutes, what do you sort of see, what were your reactions to her comments from the perspective of an academician? And as you listen to what she had to say, what do you sort of see as the most critical steps that we as a nation have to take?
Sure. Well, first of all, thank you so much. Thanks to the college for inviting me here. And boy, that was just such a inspiring talk that she gave. The whole session and Dr. Blumenthal's legacy really it just feels very present at the moment. I agree with your framing that this is really an unusual moment, and that this is a moment where everybody, from whatever position they're in, has to think about the opportunities that are available to them and pushing as far as they can now, because, you know, it is extraordinary to have someone like Dr. Nunez Smith in the White House. It's extraordinary to have this focus. And unfortunately, it may have taken a pandemic and other tragedies for this to happen, but here we are and we have to do what we can. I think I'll just say a few things from maybe a little bit the perspective of academia, 3 things. First of all, there's internal work to be done. Second of all, there's external work to be done. And third, I think that institutions have a special responsibility to their own communities where they sit. So for internal work, that can be very difficult, but it really requires looking and listening within any particular community. At the School of Public Health at Johns Hopkins, we are about a year into a process that we call IDARE, which is Inclusion, Diversity, Anti-Racism, and Equity. And that's led to a big plan that everybody is pushing forward on. It includes some things that you might expect, like an additional renewed effort on recruiting faculty from underrepresented backgrounds, as well as students, but also workshops and trainings, and really a real commitment to changing the curriculum in public health, which I think is going to be a very important internal aspect. There was really a terrific commentary by several faculty at Johns Hopkins in the New England Journal, talking about how scholars, African American scholars, sociologists, public health, have really been kept out of the curriculum, and their vision could be a way to help them, starting with W.E.B. Du Bois, talking about some of the early work that he did, really understanding the social determinants of health, could really be a defining principle for rethinking the curriculum. So there's that internal work. Then there's external, because I think particularly in public health, there are skills, there are tools that can help this effort succeed. Mm-hmm. And sometimes we think about that in terms of health in all policies, which I totally support, that we're going to review other types of policies, think about transportation, energy, other things for health. But I think it's also important for us to think about seeding our knowledge and expertise in other disciplines. And so we are going out of our way at our school. We have a fellowship program where we're trying to find people in non-public health fields to train in public health. They continue to work in their organizations and they owe an extra year back to their organization. We have librarians, we have community activists, we have police officers, we have teachers. And the idea is that the use of data, the community engagement, the thinking about policy, these are things that we can help other fields do better, frankly, and they can learn from some of the things that public health understands. And then the last thing I'll just say briefly is I think that every organization has to think particularly about the neighborhood that they're located in and what they can do in partnership to improve health in their area, both through medical services, but also through public health collaborations. And that is very important to the School of Public Health at Johns Hopkins. We have a program which works closely with 100 nonprofits. We also work very, very closely with city agencies like the health department. And I think there's a lot to be done, but it is incredibly rewarding to see progress where, at one meeting somebody said, we know that we can call and get the help that we need from the school for writing grants or staffing projects or doing things. It's not just people coming to us and saying, we want you to participate in research or whatever their agenda is. And I think that's really the kind of relationship that has to be built and sustainably.
Let me just follow up with one short question. You made an important point, but I want you to take a couple more minutes to talk about it. As you look at your external collaborators, you say that we have a lot to teach other disciplines. I wonder if you also want to say that we have a lot to learn from other disciplines. What do you think?
I think that there's a lot to learn from other disciplines, but so in the sense that, sociology, anthropology, there are a number of fields that I think we can learn an enormous amount from in public health. Public health is an interdisciplinary field, so we're just hiring an anthropologist, that I'm involved in hiring them because, those are fields that really know how to listen, know how to understand where people are coming from, put things into a structure to help with really appreciating, why don't people get vaccinated? I mean, that's a question that public health has limited answers to. You can get up to a certain point. The reason I'm wearing sneakers and forgot to change my shoes is I was out with the Baltimore City Health Department this morning in West Baltimore doing canvassing, and a lot of people interested in getting vaccinated, a couple people not interested in getting vaccinated, and what's going on, how to think about that. Those are the questions for other fields. But I don't want to be totally, I do think that if you look at fields like law enforcement, housing policy, nutrition policy, they can have many failures. I think a lot of the failures we see that are frustrating from an equity perspective are failures in other systems. And I think that we shouldn't be shy about saying that we can help. Now, not in terms of necessarily rescuing them, although we may have our ideas, but I think it is a positive thing if a housing agency is going to train someone in public health to be able to use their data and think about policy differently, or using data differently in a school system that has really struggled on absenteeism, but they're going to look at it differently. They're going to look at it geographically. So I think we can both learn, but we can also offer things.
Well, the reason why I focus so heavily on that point is I think that if we're going to make progress in this space, it's going to be these collaborations, these interdisciplinary learnings and engagements. And so I would really appreciate your response. Dr. Maybank, you may not know this, but you have focused your entire career on the transformation of the medical profession itself. You've sought to uncover, recognize, reconcile, and reform structural and other forms of racism for the purpose of assisting, in many ways, health professionals and others to understand how to honor and create health equity. At this inevitable turning point in medicine and society, I think your work is really exemplary in demonstrating leadership in understanding and connecting public health, clinical medicine, and social structures that are all hallmarks of preventive medicine. And we're really pleased that you recently were awarded ACPM's Catherine Bucco Sturgis Award, the highest award that recognizes contributions in research, teaching, and service in the fields of preventive medicine. Congratulations on that, and we love your work at the AMA. You're just a bright light. As somebody that's an alumnus of the AMA leadership, I'm really appreciative of what you're doing. Let me ask you for your same reactions on Dr. Marcella Nunez's Smith's speech, and from the perspective of organized medicine, what do you sort of believe are the most critical steps that we as a nation need to address, and the issues that she highlighted in her talk?
Sure. So one, thanks first to the college, to Donna, Stephanie, so many folks who have reached out and supported me over the years, because I don't think we can do this work without that support. So it's been really meaningful to be part of a college that I feel has my back. So I wanted to really say that. I hope I don't I feel like I'm going to get emotional through this. Bear with me. And Dr. Tuxen, for you to just say that was really, that touched my heart. It really did. Because it's not easy work, as we know. And sometimes you're not always fully clear on how it's going to land on people. And it's not that I don't hear feedback in terms of some of the work that we've done, but is it really going to be meaningful? Is it really going to create change and make a difference? And I think, that's what Marcella is really speaking of. And as I was listening to Marcella, because she is a friend of mine, I think about, just the importance and the context and the moment in time that we have to operate and work in solidarity. So it was mentioned there are many doors open at this moment. And there are many leaders who have an analysis, I think, at this time, operate with a sense of urgency that could come together in ways that we couldn't before. And clearly we have a federal administration that also is very supportive of these issues. And so, in her words, I just, again, think about the urgency for strategy and for planning and for doing at this time. And then in the context of that strategy, just really important to help educate up on what does it mean to have an equity strategy? What does it mean to have an equity framework, to do this? And so, I rely lots on Dr. Kamara Jones, as many of us know and have worked with, in terms of her frameworks of just, valuing all people equally, focusing on the historical context and making sure we're honoring and recognizing how those impacts are present today. And then the redistribution of resources. Like that simple framework, most people don't really understand that is the equity strategy, that's the equity context. And if you can apply that to the work that you're doing in your institution, you can go a long way. And so there's a lot of capacity building and still training that needs to be done, and just understanding beyond the words of saying equity, what does it mean and how to operationalize. And I think to the point that was mentioned before in terms of an inside-outside strategy, that is my bread and butter. I always say we cannot do equity work externally. We can't just partner with communities. We're not going to do that well if we don't work to change our own mental models and how we show up in this space on a day-to-day basis. And it's beyond just the workforce equity pieces of it. It's how we're doing our budget and contracting. Who are we doing that with? Who are we engaging? And how are our communications? Is that an equitable process? Our data, all of those systems within our institutions have to be interrogated and reimagined and redesigned, really, in order to do equity well and to be really fully committed to do that work. And that's the hard work, because that means then usually leaders and folks have to look at themselves. And a lot of folks aren't ready to do that, honestly. There's a lot of accountability that has to happen from the top level leadership to say that this is the direction that we're going to go. And I think for a place like the American Medical Association, with the history that it has, my success has really been dependent upon how well Jim Madera, the CEO, has shown up. And I get people evolve over time. That's the other thing, that we have to always give people the opportunity to grow and evolve over time. It can happen. Some people are not going to move, but some people will. if you're able to persuade them well enough. But I would say we've been able to get really far because of his leadership, and then also the Board of Trustees at this time and where they're at. They all agreed to do Racial Equity Institute training for 2 days, so they've all gone through that. All of our senior leaders, and actually 60% of the AMA staff have gone through Racial Equity Institute training because they've been held accountable to do so. They're going to be responsible for doing equity action plans and submitting those at the end of December. So those are just, some of the steps that have to happen, but you have to be very intentional about doing this work. It doesn't just happen, and I learned that from Dr. Mary Bassett, who was the former commissioner at the New York City Department of Health, now going to be commissioner at the New York State Department of Health. But she learned, early on in her career, she thought if she engaged her staff and said, we need to do better, we need to operate in this way, that they would automatically do it. And then she realized that that wasn't the case. And so when she came back on as commissioner, was intentional and said, we're going to start this center to really figure out how we're going to hold accountability to do this work. And I think that's Marcella's saying, we have to hold ourselves accountable.
Something that Marcella said that's very germane to a comment you just made. She talked about how the federal government resources need to be engaged more effectively with community-based organizations. Mm-hmm. And I think by inference also, knowing her, she would have added faith-based organizations as well. You used a very powerful concept, and I want to make sure you really wanted to say that. The redistribution of resources. Mm-hmm. This is going to be a very challenging opportunity and issue, won't it? And I wonder how you sort of see the role of physicians. Physicians, in many ways, it might be argued, and I'm just setting up a straw man here for you, but physicians are among the more wealthy, privileged parts of our society. I wonder how many of them will feel good about a conversation of redistribution of resources. Is this a win-win scenario or a zero-sum game that you're describing?
Well, as you know, and you're kind of tossing up, this is one of the big conversations within equity, and Kamara Jones talks a lot about this as well. It's not a zero-sum game, and the perception that it is, but it's not. And I think the conversation that we've been having with physicians is providing the data. The data tells us, that with all of our great intentions of wanting to care for people, I believe all of us really want to care for people, but our data tells us something different, that the impacts are not matching up with those ideals that we have as physicians and as an American society. And so if we want to fully live through our physician oaths and commitments that we make, then we need to interrogate that, and we need to interrogate ourselves. So you're right, a lot of folks aren't going to speak up and talk about, loss of their privilege and wanting to lose that. And so that's why you have to push the conversation in just the way that you did, because we have to address those concerns and those myths, those narratives directly. And I think that is a really important part of the work moving forward in equity. There are the technical pieces of what I just mentioned, what you can do at the institutional level, but then it's that cultural change, value change, principle-based part of the work. If we are not kind of aligned and moving, in the same direction in that way, we're not going to end up with good outcomes. So as an example, we have to think about the narratives in this country that undermine equity, so individualism being one of them, right? The myth of meritocracy, the myth of a hierarchy of human value based on skin color with white being on top, otherwise known as white supremacy, the zero-sum game myth. All of these othering and belonging, all of these undermine our ability to fully understand and own who is responsible and who has true power in that space. And we have to name who has the power, and then we have to hold accountability to redistribution of that power, whether it's through finances, people, political power, all of that.
Well, you've opened up a lot of issues we will come back to in just a minute. And by the way, I do want to also acknowledge Jim Madera. I think he is a very important leader through this time, and from everything I have observed in my own conversations with him, seems extremely committed to not only the agenda, but supporting you. Yeah. And I think in your job, and I don't think you can succeed without that. And so thank goodness for Jim. Chris Purnell, you may not know this, but you are the Chief Strategic Integration Officer and Health Equity Officer at University Hospital in New Jersey, where you regularly demonstrate and I have observed this, your dynamic physician leadership as a social change agent. In your public health practice, you have been focusing on health justice, community-based advocacy, and population-wide health promotion and disease prevention initiatives. You are the first ever Chief Strategic Integration and Health Equity Officer at your hospital. You're overseeing a great portfolio of population health, strategic planning, community affairs, and something that I really enjoy called human experience, which is an exciting concept. I'm also glad you got the ACPM's 2021 award, named on behalf of somebody who is very close to me and somebody that I came to love and respect, Ronald Davis. Ron, you received the Ron Davis Special Recognition Award, honoring outstanding achievements and contributions to the preventive medicine specialty. And I'm also really pleased that last night I called you on the phone to ask you, would you catch an airplane to Portland, Oregon on no notice to do something that was profoundly important to the COVID fight. And I just knew that I was going to get this screamingly mad email back, "Are you crazy?" And instead, the response was, "Where do I have to go and how do I get there?" And she will be in Portland tomorrow taking care of serious business on behalf of trying to fight COVID. So from your point of view of a university, of a hospital leader, your response to what Dr. Marcella Nunez-Smith had to say, and sort of what do you see as being the key challenges that we have to address?
So first and foremost, I am thrilled to be here. I love being a preventive medicine physician, so thank you to the college. Thank you for the opportunity to be here and to be in between Aletha and Josh. It's heartwarming. I trained at Hopkins. Aletha and I have partnered across work in New York City, but we are at a pivotal time, a poignant time, and I believe that's what Dr. Nunez-Smith says, is so many of us are echoing across this equity echo chamber. But what we can't lose sight of is the human experience. Too often we talk about equity from an esoteric, theoretical, or conceptual space, where equity is really how do people achieve the fullness of their well-being and ability to function in society. What does that look like? What does that look like for the persons whose house was taken from them or displaced? That's how my hospital came to be. University Hospital in Newark, New Jersey. This hospital has been a bedrock in the community. It's not possible for an institution to understand equity without understanding how injustice, racism, oppression, sexism, white supremacy, the oligarchy and the patriarchy has undermined the wholeness of souls, the wholeness of lives. And it can be hard for institutions to talk about lives unless they're talking about covered lives. It can be hard for institutions to talk about humanity without talking about disease or diagnosis. But I think equity in what Dr. Nunez-Smith is saying is equity determines and requires for us to show up not so much as who we are in our function, but who we are in the human diaspora, who we are in the spectrum of humanity. And for a hospital to be able to sit back and say, who are we in the spectrum of my particular community, Newark, New Jersey? How did we come to be? Why is it that we see both the beauty, the richness, the diversity, the complexity, and the pain, and the prejudice, the poison? But what is the responsibility of a hospital? Gone are the days of a hospital just being a brick and mortar institution and talking about how do you treat or diagnose disease. A hospital has to be at the table of the human family, talking about how do we all survive and thrive. And that very much looks like our policies around procurement. That very much looks like who do we hire. That very much looks like what are the services that we provide. Do we provide services that speak to or speak with a social and a cultural fluency? I've been talking about this idea of social and cultural fluency, and people are like, you mean competency? No. You mean responsive? No, I mean fluency. Can we as institutions lose our rigidness and speak in ways that impact people. Because when we do that, we speak through our actions, through our choices. Our budgets say so much about us, right? And if we're ever to get to an equity in all policies approach, I like that spin on health in all policies. If we're ever to get to an equity in all policies approach, we have to be able to interrogate, to question, to challenge our status quo. What I see so often in hospitals is institutional inertia. It's to protect the status quo. Is to be able to talk about change while still protecting the status quo. You know, we have this question in healthcare, but is this the place of the hospital? Or is this the place of the physician? Or is this the place of the healthcare system? Or is this the place of the academic institution? And it is our place. If it is not our place, then how do we operate in that human family? So I see her talk as a call to action to be able to do that. And that is hard and through the lens of a hospital, especially a safety net institution, especially our hospital, which is the state's only public academic medical center. It is hard because we're often challenged with few resources. And equity always demands a conversation around need, so a relationship to need. And sometimes in the hospital space, especially in the safety net hospital space, we think, well, what is it that we can do well with the few dollars that we have? When we have to think about how can we challenge the premise and the notion of how we prioritize these dollars. Not what can we do well with the few, but how do we challenge the notion of what we prioritize with these dollars. And I hear that. I hear that across the different types of work that we do. And that's going to require not just hard work, but heart work. Do hospitals have the heart? And I'll leave it there.
Let me, you've hit some important ones. I'm going to give you what I think the answer to my question will be, and then I'll ask you the question. Focus on need. That's the answer. Okay. Question. You're saying that, you say, how do we all survive and thrive? A hospital has, maybe yours a little different where you are, but generally hospitals have a broad catchment area. There are lots of different people that own that hospital, that are part of that constituency. And I'm wondering, is the conversation about equity and us against them conversation? We'll come back to the zero sum. At some point, in focusing so intensely on the wholeness of some people, then there are other people. Do they feel in this conversation that, again, we are, because it could be competitive, that we are at a divide, we are back into our tribes, and America goes down the toilet faster than some of us think it is going now? How do we deal with that conversation between those with and some who may be on the margins but not complete? Or is it that we focus on need?
Fascinating, right? I'm smiling because I was having this conversation the other day in the hospital. And I'll start with like Aletha, like so many of us who are doing this work right now, we've been impressed upon by the great Dr. Cameron Jones, right? And so when you're talking about the definition of racism, right, a system of structuring opportunity whereby one group is advantaged, another group is disadvantaged, but the strength of the whole society is sapped. And in talking about that in terms of a hospital, yeah, we look at what we are now calling our CSA, like our core service area, right? For us, that's about 7 or 8 zip codes. That's like the whole of Newark in one other city. Then we look at our PSA, that's common language for hospitals, right? So our primary service area, that's about 27 zip codes. And so we oftentimes find ourselves, because we are a state hospital, right, at the fulcrum of that CSA and that PSA. but I can tell you that the whole of the patients that we serve cannot receive the best of care, the safest of care, the most high quality care, unless the most vulnerable of the patients that we serve have equal access to that. And I can give you stories about that. So I'm in the morning huddle, and there's an ask from our director who heads our neonatal NICU, and she says, we need cuddlers today. We need cuddlers today. And I want to stop there. Yes, there is a young teenager who's losing his life to a motor vehicle accident, or yes, there is another patient that we're dealing with who has a different issue that's happening and it's impacting their family, but we need cuddlers there. None of us in the hospital as a whole system can be effective on throughput in doing our job unless we recognize that the most vulnerable in the house today need cuddling. And I use that analogy because we can't lose sight of that. And the practical nature of that is when we as an institution, we align ourselves or ally ourselves with the mayor of Newark, and we say, look, we're going to go in on Newark 2020. We are going to aim to hire a certain percentage of workers who are from this city. And we talk about that and we say, but what does that mean? What does that mean for someone who's not from Newark? This is a state hospital. What does that mean from someone who is not of the racial and ethnic composition of Newark, majority Black and brown city? How does that impact them? It impacts them because if this hospital can't serve the very community in which it sits and it rests, then this hospital can't be that tertiary referral system that draws patients from the other regions of our state and the tri-state.
To warn the audience, your turn is coming in a little while. I get to have the privilege of asking each of them one more question, and then we'll turn to you. So don't be frustrated if you're something that you want to come back to. Just don't forget what you want to come back to. Josh, as we look at the conversations that America has to have about race and racism in a highly polarized environment, what's the role of the academy in having those conversations?
Well, that's a great question.
How do you talk about racism and the history of racism and all of that?
Got it. Well, you start with racism from the academy, and particularly as we're a public health school, the racism in public health. I think it's important to acknowledge that first. We have people talk about Baltimore being the originating city for redlining, for example, and segregation, but not everybody knows that actually started with labeling certain neighborhoods as high risk for tuberculosis. It actually came out of public health, where that had its origins. And so I think it's important to recognize that to start. I also think that there are conversations that, the academy can play different kinds of roles. I think, as you alluded earlier, understanding racism is an academic area of inquiry that is extremely important. Understanding how people think about race and how people apply race, and identifying the legacies of racist practices. We're seeing that more and more, I think, in medicine as people look at different formulas and realize, why is race considered a factor in this formula? So I think there's a role in the history, there's a role in the present conversation, there's a role in understanding racism and its effect today. There's a lot of work to do for the academy in this area.
One thing I'm impressed by your comment, and it's also something that you also said, Dr. Maybank, and that is this focus on training ourselves. We have to talk internally. We have to teach each other. And I think that's important. But I wonder, one of the things that, and I'll be, frank about it as a Black man, sometimes Black folks get tired of explaining this to white folks. It drives us crazy. It really does. It really does. And at some point, you just would hope that white folks would talk to white folks. Black folks can't solve this problem, and certainly not by ourselves. There has to be other conversations. Do you think it's important to challenge the white academicians to be more involved in their community and having the conversations?
Well, I think understanding racism is in part understanding people who have racist ideas, how those are expressed, and how those can be countered on their home turf. I mean, that is part of what you have to do. So, I mean, absolutely, I agree with that premise. And, you know, I don't think maybe there's, you know, one thing academic institutions can do in that area, but there's probably a lot. And I really do think we need to be thinking about what produces racism, what perpetuates racism. I will give you a very specific example. The misinformation that is now coming at people in, you know, a flood of misinformation. It could be about COVID. It's about a lot of things. There's a lot of racist misinformation that's coming at people through social media. That is an extremely important threat, and I think the academic world has a really important role in understanding what's happening, how misinformation affects people, and what can be done to counter it. And so I don't think this is an example of asking, you know, people who have experienced racism to explain it. I think this is really what is at the core of producing a lot of racism, and how can we, you know, develop policies, put them into place that really are prevention.
I think the misinformation question is really, really critical, big issue, social media stuff. But yeah, it would just be so wonderful if more of our colleagues could be involved in those community conversations. However, before we start sending your colleagues out into their communities, I think we all have to learn the lessons of public health officials being beaten or threatened and followed home. And so I guess this is not without a need for a certain kind of courage if they are going to engage in these conversations. This is not an easy time. Let me turn to you a bit, and again, I've highlighted and how celebrating I am of your internal curriculum work and your internal AMA strategic efforts. What do you think you're going to start doing, and what can we expect from you and the AMA in terms of other activities that are going to be offering other kinds of services to this agenda?
Yeah. So, so we released a strategic plan. It has 5 approaches, and the first one is embedding equity. That's all the internal work. But the other 4, and the second one is building alliances and sharing power in unique ways. So, as an example, working with the physician groups that have been historically marginalized and minoritized. Most folks know AMA on policy and in practice excluded Black physicians, but there's lots of other harms that happened. And so I think it's critical that we as the AMA do things differently as we relate to the physician organization. So sometimes it's shifting resources and giving resources to NMA, NHMA, GLAMA, all the groups that we know exist now, and do things in partnership in which it's not us as AMA saying this is how it should be done, but providing space for these conversations and planning to happen in a different way. One of them actually is now a partnership with ACPM. It's a CDC-funded grant in which we have all the minoritized physician groups and their presidents are engaged to be a part of a process of choosing 20 BIPOCs, by BIPOC I mean Black, Indigenous, people of color-led physician practices across the country, and kind of help support them identify and measure and track best equity strategies. And so the processes that we're using and developing an RFP and all of that, it's not just us as AMA saying this is how it should be done. The process, is much more probably timely than people are used to, but I think it's really important in terms of making sure we're really valuing the voices and really centering the voices and experience and ideas of those who have been most marginalized within any of our spaces. That is a core equity principle. And so that's just one example of how we're doing things differently. We also have a strategy of ensuring equity and innovation. So innovation, is a value, especially in healthcare. I'm a public health person. I clearly am part of the college. I've spent most of my time in public health. But this context of innovation within healthcare really aligns with technology. And we already know it's a very exclusive space. Predominantly white men who get to make the decisions, design, and profit. And so how do we disrupt that? A lot. And so we are working now with an external advisory committee of many folks who are at the intersection of innovation, whether it's venture or at a hospital or whatever it is, to help inform what we're doing. And so we're going to be putting forward principles of what it means to do equitable innovation, to help hopefully drive some of this work that's happening across the country. And then I would lastly, well, there are two other things. We have pushing upstream, so addressing all determinants of health. There's a lot that we can do to help support physician and building physician capacity to better understand what does it mean by what do we mean by social drivers and structural drivers? How do they show up? How do they influence? Clearly the system, and our system is not well equipped for physicians to even minimally address social needs, and then even to address the social drivers of which some of you mentioned kind of your hospital is starting to do. There are probably more possibilities around that we see happening. And so we as the AMA are partnered in Chicago with an initiative called Westside United, which is completely neighborhood, community-driven opportunity. 6 anchor hospitals, along with the AMA, are investing several millions of dollars within the community of Westside United for upstream opportunities around business development, affordable housing, et cetera. So we just finished our first round, and I think what's really great about that on many levels is that we do have like this social impact analysis that we're working towards to kind of really collect data around this over the next few years. But there are other models like that building up across the country, but I think that's an opportunity we're diving into. And then lots of education. We just launched like our Health Equity Education Center on the AMA Educational Hub, from anywhere from LGBTQ health to anti-racism work, all of these different opportunities for education. And then lastly, I'll mention, which is to me kind of near and dear to my soul and spirit and heart, as you've mentioned, is our work around fostering pathways for truth, reconciliation, and healing for our AMAs past. And knowing that we have many decisions that harmed and remembering that harm, but also just decisions that really just don't demonstrate care. So it's not just about not doing harm, but how do we set up systems and imagine systems for care? But how do we recognize the kind of quantitative impacts of the decisions that we've made as well as qualitative? So again, as an example, excluding Black physicians for over 100 years is problematic on so many levels that has impacts to this day, right? It prevented, back then for those who may not have known, in order to get privileges to a hospital, you had to have membership into a medical society. So if the medical society is excluding you from that, then you have a whole community that's really struggling to find work on many different levels and struggling to take care of their patients. And then you have the recommendation of the 1910 Flexner Report that was commissioned by the American Medical Association, funded by Carnegie Foundation, that recommended that 5 of the 7 Black med schools be closed down. So, all of this has lasting impacts to the day, and we have to fully own that. And so this past June, the House of Delegates did pass legislation and a resolution to interrogate and investigate the impacts of the Flexner Report and really look into a truth and reconciliation process for Flexner. So, there's lots of movement. And I have to lastly say, though, and give credit, and I think this is the opportunity for the Academy as well, are the students and the young physicians. They're the ones who have the analysis. They're the ones who have been pushing and organizing from Black Lives Matter movement till now and all, White Coats for Black Lives. It's really these young folks that I think are pushing the AMA and many of our institutions to do differently, and we have a lot to learn from them, and they're going to be the leaders of the future. And so the more we engage and value and center their voices and ideas, I think the better off we will all be as institutions.
I hope that on your reconciliation efforts that we will hold true to the traditions of our profession, which is to do things meticulously, study them carefully, absolutely, lessons learned, record it, and then share it for constant feedback. The point I'm getting at is that this is such an important idea, this reconciliation opportunity. I would hope that it becomes a model for others to use in our conversations throughout society. And I hope that you will publish it, not in the Journal of the American Medical Association, but on the front pages of the Wall Street Journal and other social accessible opportunities. I want to ask you a quick question and then switch it on over to Chris for the same question. Reimbursement is fundamental to changing how anybody in the health professions behaves. Hospitals, for sure. We have measurements that we use to measure the quality and appropriateness of care, including, although underemphasized, of the triad of quality measures, performance measures, but then patient satisfaction measures. Do you see the AMA having an opportunity to influence the patient satisfaction measures that will better align with the lived experience of patients of color and those that are marginalized in the healthcare system? And secondly, would you think that it might be possible to support a new measure called equity?
Yes. Yes and yes. So that is part of our work, actually, that we are starting. I named a few. I can name a few more. In terms of pushing upstream and addressing root causes. And so led by Vice President on my team, Karthik Shivashankar, who comes from BWH in Boston, and really focused a lot on kind of that quality and equity component. We know equity has really been left out of the quality conversation in terms of action and conversation really since its beginning. And so now we are looking to launch several things. One is a measurement for equity and anti-racism that institutions can use. But I think the opportunity at AMA is that because of our power and our influence, we're able to be at the table with Joint Commission and CQA, all these folks that we are now engaging with, to think through how can we build this into our structures and learn all at the same time in terms of these different measurements. The Loan Institute has been doing a lot on really kind of measuring hospitals and the levels of segregation and all of that. So we're working towards creating opportunities around that. And I also think a lot of our institutions and hospitals want the opportunities to learn from one another. And so we're launching a peer network for hospitals to engage in many different levels around what does it really mean to work at your system level through your Q&I or quality and safety initiatives to really embed anti-racism and equity work. So there are multiple levels that we're working at, from the institutional level to the structural level.
Chris, your perspective.
Definitely. So I'll talk about some of the insight work that we're doing to give a lens from a hospital's approach. So we're looking at the work of the Loan Institute, right, and not just lauding how University Hospital has performed, but why are we able to perform well on some of those metrics, but not as well on others? And are there other metrics we should be intentionally considering? We're delving down really much into that zip code analysis, right? So a hospital frequently is concerned with its leapfrog. A hospital is concerned with its CMS star rating. But if you begin to stratify that data and see how you perform on issues of importance to the primary communities, and regions that you serve, a metric has to become patient satisfaction scores in the African American community that uses the hospital specifically. And so we have developed 5 strategic priorities around equity, map that out onto a 10-point plan, map that out onto about 30 or so objectives with 122 goals and measures. And we're looking for the specificity like that. How are we performing with outcomes and stratifying it by real data, by SOGI data? That's what's going to be very important for hospitals of the 21st century and beyond, because right now at baseline, we don't have appropriate metrics, right, to fully interrogate and evaluate what we're delivering. You know, we're on a high reliability journey, and constantly we're talking about that high reliability journey is nothing if it's not also a journey around understanding anti-Black racism, not understanding how hospitals have failed to share power. And so equity has to be built into safety, has to be built into quality, has to be built into experience. So you need the metrics to measure whether or not you're doing that successfully.
Let me sneak in one little one and then turn to the audience. But Marcella talked about data. Each of you have talked in one way or another about data. When it comes to data for people of color, it sucks. That's a polite technical term. What are we going to do about that?
I got to start with, yes, it sucks. You know, when we sat down to internally to ask ourselves, you know, how are we performing, there was a paucity of data. There was a paucity of data even about are patients who participate in the HCAP survey, right? So there are patients that we're not hearing about their experience because they don't even participate in the HCAPS data. Or how are we stratifying data? Is there intersectionality in the way that we're stratifying it? Are we democratizing data? Meaning, are we sharing it? Are we sharing it not only within our institutions? You know, I talked about that inertia. I was just saying to a peer the other day, too often in hospitals, it's like the Voltron and the Transformer spirit. When you bring change or innovation, the system says Transformers and like arrays itself to protect its status quo, right? So it's like democratizing the data so that we can see where we need to change and allowing the community to see that data and inviting them into that process. So paucity of data and then democratizing the data, I think, are two places we must focus on.
So Joshua, I just, I don't want to put my finger on the scale by asking the question this way, but I know we know from our COVID experience how relatively few states collect information on race and ethnicity. And so that all of our reports are based around like 19 states, you know, it's like that little group. How important is it, or is it important? Let me be more fair in the question. Is it important for the Academy all across, in all of our states, to be vocal advocates that to permit the public health departments to be able to collect this information?
It's extremely important. In fact, Johns Hopkins not only just reported from the states that had the data, but put up maps of which states weren't reporting. You know, for that exact reason, to try to call them out, wrote op-eds, said like, this is unacceptable. You know, if we're gonna really understand this challenge, we have to have data that really shows where it's impacting. We also did a public comment period last year with the Center for Health Equity at Johns Hopkins about how to measure health and equity for hospitals and health systems. And we ran into exactly the issue that you're talking about. So few metrics able to be disaggregated by race, enormous frustration that traditional quality metrics for health systems really don't address equity very well. The step that we took, given the Lown program is excellent, but they're trying to find data out in the world, and there's not that much data out in the world. We wound up working with IBM Watson and trying to develop a metric focused on community health and equity. And the initial pass was to ask to focus a lot on community health. So this is separate from the question, which is extremely important and we flagged, of how do you measure what the hospital does within the hospital in a way that really answers key questions of equity. But what's going on between the hospital and key issues of community health? Because hospitals are often located near communities that, you know, are communities of interest. And if you can track data for that community, you are measuring something extremely important for equity. If you can say like these are the infant mortality rates or the smoking rates or the overdose rates or whatever it is, you are, you know, committing yourself to an equity project if you can do that, as the data may catch up. And we wound up developing, you know, measures in 3 areas: what services the healthcare system provides that really matter for community health, what partnerships the hospital has in the community, and the third is the hospital as an anchor institution, what policies it has for its procurement, its leadership, how it treats its staff that really matter for community health. And they did that as a survey. It turned out of the top 100 hospitals, 40 of them switched places when they included that measure. And so the goal is to have that kind of, you know, accountability built into all the core measures and systems, I think, in order to drive change.
Audience, it is your turn. The first person that stands up to ask a question gets a special award. Please stand up and tell us your name.
Hi, Boris Lushniak. I'm the Dean of the School of Public Health at University of Maryland in College Park.
Good, let me give you your award. Everybody, round of applause.
And that's all I have to say. Thank you so much. A public health practitioner by background, 27 years in federal service, and now 6 years in academia, right? As a dean of a school of public health at the University of Maryland in College Park, 2,400 undergraduates in the public health program, which is really extraordinary. And on top of that, a school of public health with 300 master's level and doctoral students. And I kind of view this as you stated already, the whole future of this really depends on the students. And I guess to the whole panel is, what's the right approach regarding students, right? Is it the idea that allow them to be mentored, to be led, to be, cajoled, or allow them to lead at this early stage? What's been successful from your perspective? And specifically, something that we oftentimes neglect in the preventive medicine and public health world is bringing up the ethics of our professions. The idea that we belong to a do-good specialty, to a do-good movement that is based on what? On love and respect. And that to flourish in this specialty, it's impossible, I view it, to be a racist. It's impossible to be intolerant. It's impossible to not take into account diversity and inclusion if we are to be effective.
Good.
What's the effective approach regarding students from your perspective?
Floor is open. Who wants to take it?
Okay, sure. Well, yeah, let's go. So, for me, for students, I don't even know why, honestly, there would be a question of why we wouldn't let students lead and provide voice and provide ideas, especially considering, again, they're going to be the leaders of the future, but also considering they have really great ideas about where education could be and should be. I think also in terms of students now, they're students. So we can't, because what I'm hearing at this time from a lot of students in the space of equity and anti-racism work, they're also feeling really lonely. One, because there's just the lack of support from top level leadership, so usually the ones who are kind of pushing it, and so they're not fully being listened to or acknowledged or brought into spaces. And the reality is that most faculty really don't have a clue on how to even educate up on or educate students on all of these principles around equity because they weren't trained on it. And so I think it's imperative that we evolve our models, of education and value, what you're mentioning, of the voices and ideas of young people, to be a part of our strategic planning processes, as we start to lay out and move forward for the next years or so. That's my position.
Good.
Yeah, I just add something really quickly to that. So often we talk about how institutions or systems fail to share power. It is in sharing power with community that hospitals can truly live out their anchor model. The same is true in academia. We were all students at some point. And before I saw the light and became a preventive medicine physician, no offense, I thought I was going to be a neurosurgeon. But what really drove me out of becoming a neurosurgeon was a lack of opportunity to share power, to be mentored, and where my lived experience was an expertise that mattered. And I think today's students are coming of age in such upheaval, whether that is social, cultural, racial, and identity-based, that they are experts in their own right, and we need to empower ourselves by sharing power, because I don't think you empower another person, but you empower yourself when you share power, and give students space, give them voice to add to processes. Just like we talk about giving community, give students that space. Oftentimes, you'll see students will come with other assets, right? I'm using language that I use when I talk about community. What are the assets in this space that we're not bringing to the foreground? And students will have assets. Those assets can be around organizing. Those assets can be around other forms of communication. Those assets are ways of being influencers. And so frequently, we're talking about sharing power with community, asking community to take the foreground, to leverage those assets. Do the same with our students. do the same with our students and allow our practice to become informed by it. And in turn, we must be accountable to mentor. We must be accountable to, even when we don't know, to say and admit what we don't know in front of our students. That's another thing that institutions struggle with community, admitting what we don't know or admitting what we're bad at, but then being committed to learn and committed to get the resources or to go to the resources that can do what we want to achieve.
Yeah, I'd just like to add another dimension to this, which is that in public health, we can find people who are really doing incredible work and bring them into the field of public health. And so our students, we have as a student person whose day job is to run the community anti-violence initiatives for the city of New York, or someone who is running homeless services for adolescents in a county in Michigan. I mean, it's not like putting on a new leaf to say, well, we can learn from the students. I mean, the students are the teachers. They have like tremendous amounts of experience, and we designed this to say, once somebody is, past the bar to get in, which actually we're having discussions about what the bar to get in is, the GRE is no longer required. But once someone's in, we're not going to base a decision on a full scholarship based on how high a score is or what their GPA is. It's really that they are doing incredible work in the areas that we're focused on, and it is changing the school. I mean, this is through a program called the Bloomberg American Health Initiative, where we bring in 60 people like this on full scholarships every year. We're up to about 210. And most of them are still working while they're taking classes, and it is having an effect of changing the school. We've had mini rebellions in a few classes where people said, do you know what they tried to tell us about leadership? And I'm like, I'm not sure I want to hear, but I'm sure I can help, negotiate a better, what we're going to do differently now. But, we have one of our students led the Oregon referendum on decriminalization. I mean, she has just tremendous amounts to teach others. So we're well within this idea that, and they don't all have to be young people, interestingly, so we're well within this idea that we need to have with our education, a foot in the world and using the education to really change what the school does.
I just, Dean, I would say, those of us who are not currently in the academy really would have to be frightened for the challenges of the pedagogy that you have to teach. And I think these young people who are so filled with, hopefully, idealism and passion, that's essential. It's the fundamental. But then comes the competence. How good are you at translating your passion into something meaningful in disciplines that are not normal for the public health community? Housing policy, transportation policy. How do you create the financial incentives for a grocery store, and how do you get the insurance for the grocery store in that community so that you can establish the grocery store? I mean, the elements that are involved in today's public health world are very complicated, and they go well beyond. My generation, a lot of us could sort of, because we had the passion and we had the right attitude, and we cared. That was terrific. But today, that's got to be much more granularly transferred into a new set of skills that is not traditionally taught in our schools. And so, thank you for the work you're doing, sir. Those of us who are outside of it now, and in terms of sharing power, I followed David Satcher to Charles Drew, where I got to be the president of Drew in South Central Los Angeles. I was so excited to have my data. I knew exactly the epidemiological challenges for that community, and we were going to have a town hall, doggone it, a community meeting, and we were going to have the thing, and we knew exactly what the data was showing and what we should be prioritizing on. And the community said, who are you? Well, where have you been? And by the way, who do you think you are to tell us the agenda with your data? This is what we want to do. And we had to reorganize, take another look, and understood that finally, all you had to do is build a highway. You can run any car you want once you build a highway. They want to do diabetes, and we want to do HIV. Hey, let's do diabetes. But once you build the road. But this idea of sharing power was painful. because we've got a white coat on, our stethoscopes dripping out of our pocket, don't you? And you know what we had more than that? Good intentions. Good intentions ain't gonna cut it by itself.
Let's comment on something that
Please,
you just
that's
said.
why I was trying to steer you up.
Oh, okay. All right, I'm up, right? It goes to an earlier question in terms of you were asking, you know, is it public health's role to also learn? And so when I was former deputy commissioner in New York City Department of Health and over our neighborhood efforts, and I think what the gap is, and I think there is a certain amount of supremacy, physician supremacy, public health folks have some supremacist ideas as well. And I understand, you know, there's a lot that we understand in the scope that we understand, but we don't understand the nuances of how systems work. And so when we would try to work with the planning agency or the housing agency or the transportation agency, what became very clear is that we're all sitting at the table and it all sounds great, but we're all talking a very different language. And so if we don't also prioritize and create opportunities for students to learn other languages, in quotes, I think we're not, it just adds another barrier. And I think there's just a huge opportunity for there to be greater exchange of learning experiences with other kind of city agencies, state agencies, whatever it is, in more intimate ways. I mean, we created a board game on zoning. And so we had the planning teams from New York City and the health department teams, you know, learning from what it meant. I had no idea what zoning was about, really, until, you know, I went through this process. But I think we have to be very intentional about that type of learning in order to talk about, you know, how does medicine and public health come together, you know? And that's a big one, right?
I'm going to stop you right there. That's
Exactly.
a powerful one. I want to see if there's another one from, by the way, for the organizers, we know exactly what time it is. We know we'll stop by 5 exactly. And my panelists need to know that there's going to be a lightning round where you get like 30 seconds to say that thing which you will kick yourself in the behind that you didn't get to say as soon as you leave the podium. So I don't want you to have bad feelings on the airplane. Audience. Yes.
As an aside, you said, I'm tired of explaining things to others about what my experiences are. As a white woman, how can I learn unless you tell me?
Comments?
Oh, go ahead. Nope, I just spoke. You go ahead.
By the way, that's a great question.
Very good question. I like to dance, right? But I had to put in the work to perfect my dancing skills. There was a responsibility that I bore individually. I could go to others who could point me in the direction of the Alvin Ailey, the Martha Graham, the Bob Fosse, or the Kid on the Block, but I had to put in the work. I had to put in the time and the passion to sometimes unlearn what I thought was a style in order to learn the mechanics of the style. And I use something just as basic as dance because it has no positive or negative, right? And so whenever you hear a Black person or any person of color or LGBTQ person or however someone identifies themselves express a tiredness of always having to be the one to speak and to explain, there is an equal responsibility and accountability in unlearning on the one who may bear more privilege. It is not that you don't need the exchange or you don't need the opportunity to also hear, but institutions, individuals, systems have to put in the investment to do the work. And I think that's what you hear oftentimes, people who are from minoritized or marginalized groups, is that the onus or the burden or the weight or the priority is, or the primacy going first is on you, as opposed to the systems that have more resources and assets and have the power and privilege beginning to unlearn. And a lot of unlearning starts with questioning. Questioning if the status quo should be how the status quo is.
Lisa?
And just to add to that, and this is very simple, usually I'm very direct about this, but there's too much out there now. There's lots out there, it's not too much. There is plenty out there for you to learn yourself. How to be an anti-racist from Ingram. The Sum of Us by Heather McGhee, excellent book. There are lots of trainings. You have Racial Equity Institute, you have Race Forward, you have the People's Institute. There's so much out there that if you are really committed to doing this as a white person, you will seek it out, as you would seek anything else out that you want to learn and know better, if you're fully committed to it and if you really value this work. Anybody who has not done that, to me, is not demonstrating value for this work, because there's just so much information out there now to learn from oneself. And then, I think important is to operate in solidarity and to connect with your community of white folks about these issues, because there are things that you can talk about that I can't even help you as a white person, and that's real. And these systems ultimately are sustained by whiteness and white supremacy. And so we all have to know that, and there has to be ownership of that as well.
I really appreciate the question as well. And what I hear you saying, I completely endorse my colleagues. What I hear you really saying, though, is an honest and sincere desire to learn. And that has to be celebrated and applauded, and good on you. I think what we're sort of all in common cause here saying is that the basic civilizing and human values is not something you need education on. And that's really the conversation that we're talking about. It's if you're a Christian, and what was the ethic of Jesus, and what did Jesus really teach us? And when we go away from that, those that are in the Christian community, the Jewish community will have their own conversations. But it's clear that you don't need to hear from people of color the basic fundamental civilizing values of the worth of the individual, and how we've got to connect. I think there's something else underneath your question which we won't have time to deal with today, but it's because I got to do the lightning round and not fall under the anger of Grande. But that is, how do we talk to each other? I for one am sick and tired of the tribes. I got to find a way to reach beyond the tribes. I got to find every way, and I am searching my heart every single day in my own personal journey. How do I come out of my bunker and stretch my hand across to somebody who I absolutely, totally do not agree with? But how do I have dialogue as an instrument of peace? And those are the real issues. So that's why I want to really, again, thank you for the humility and openness of your question, which provoked us to make these comments. Lightning round, and I'm going to start with Josh and then go to Aletha and then Chris. 30 seconds for the thing that will torment you for the rest of the week because you didn't say what you wish you had said.
Well, I want to say in answer to that last question, to read, there's a lot to read to start from many different perspectives. I would also say that this is a moment both for introspection and for action. So there's a lot of painful introspection that is very important, but we can't just be focused on that because of the moment that we are in as a country and the opportunities that a crisis like this presents. And so I think we have to be willing to lean in on the action even as we're leaning in on the introspection.
Aletha?
Yeah, I was about to say something extremely similar to that. I think the bottom line is that we all have a responsibility, we all have an opportunity to figure out how we're going to show up as individuals, as leaders, within any space that we're in, whether it's within our workplace or within our home, because they're not disconnected, and with our friends and families. And so I think, again, there's an opportunity for us to learn, to grow, to hear things, to experience people that we've never experienced before, if we're really committed to this space of equity and justice.
Thank you. Chris?
Just to remember that equity is just the beginning. I think the goal is justice, and that work is different work. And that if we all can commit to ultimately justice work, it requires unlearning, it requires a reprioritization, and it requires seeing the fullness of humanity. And the other thing that I would say is that knowing that something is large to solve, you still have to start somewhere. Because going back to Dr. Jones, racism is often inaction in the face of need. We all must start somewhere.
Ladies and gentlemen, please thank the panel.
Wow, what an experience today. It is a pleasure as the president of the American College of Preventive Medicine to have the distinct opportunity to thank everyone for being here today. I'm Tonette Krause-Wood. I'm a professor of medicine and epidemiology at Tulane University, but for today, I am just so proud to be the president of the American College of Preventive Medicine. Certainly, we have learned a lot. If I heard one thing loud and clear, not only do we have a tremendous opportunity to pay it forward and to train, but we have an important responsibility to learn, and thank you for that opportunity today. I want to congratulate our inaugural award winner, Dr. Nunez Smith, and thank her for her presentation. I appreciate, as we all do, the sincere and the heartfelt stories shared by Dr. Speers and Dr. Satcher for our awardee, our nominee here. So that's terrific. Dr. Tuckson, thank you. You're an incredible moderator. I've actually seen you many times on the Black Organization for COVID, against COVID, and it's a pleasure to see you again here in this opportunity. And our star-studded panel today, including Dr. Sharfstein from Hopkins, Dr. Purnell from University Hospital, and Dr. Maybach from the American Medical Association. You all did a tremendous job. We shared your stories, your motivation, the leadership. John Maxwell said, leaders are those who know the way, they go the way, and they show the way. And each and every one of you have done just that today. Thank you for sharing your insights, your perspectives, and your stories. As you all know, the American College is a membership organization for physicians that are committed to preventive medicine. We have also learned from COVID, and it was mentioned at the panel today, that in many ways, physicians and other healthcare providers have been regarded as the most trusted sources of information about COVID, about other things related to health and wellness, and perhaps even quality of life. That's a tremendous opportunity for us as a physician organization, but it also bears a tremendous amount of responsibility. Equity, diversity, and inclusion are the foundation for our success going forward. And in the initiatives that we outlined for the college just several months ago at the PM21 meeting, we said that we would focus on our visible presence and purpose, that we would focus on evidence-based strategies and solutions, and that we would be committed to the training of the future of the preventive medicine workforce. I must say, I was so pleased to see each and every one of you reference the need for us to integrate EDI into each one of those initiatives, because each one of them are important for us to move forward. EDI is not an add-on for the college, it's integral to our success. And what are we doing to do this and to make sure that we uphold our commitment for EDI as a foundation for our success? Well, we're committed to the training of our senior leadership at the college, developing educational modules for our membership. We are engaged in our recruitment strategies with our membership, and we are also securing grants, partnering with the AMA, the Centers for Disease Control, and other organizations, where we can identify the issues around social determinants, not only of health, but of wellness, well-being, and quality of life. There is a lot of work for us to do at the college. There's a lot of work for us to do nationwide. It's going to take all of us. If we're going to make a difference in our community, if we're going to make a difference in our nation, and if we're going to make a difference worldwide. You referenced the hard work and the heart work. The college is committed to both. And as a membership organization, we are going to move forward on the pillars that we can motivate and extend our offers to our membership and those beyond to make a difference for our communities and beyond. I want to thank everyone, not only those who presented here today, but also for our attendees, those who are here physically and those who are here virtually. I want to thank the staff at the ACPM. I know how hard they have worked in coordinating this, and it always takes a whole team and a whole family and a community to make it work. So thank you all very much. And now, as we're going to begin to transition from the end of the formal program onto our social event, which I know I'm the only thing standing between you and the social event, but here we go. I want to make sure that we recognize Otsuka. Dr. Mirza Rabin, who's the president-elect of our American College of Preventive Medicine. He's also the senior vice president of the organization, as well as the chief global pharmacovigilance officer at Otsuka. We are very grateful for their support of the reception that we'll be having just momentarily, and I would like to invite Dr. Rabin to come up and say a few words. Thank you all again for being here. A heartfelt appreciation to each and every one of you.
Thank you so much, Tanette. I'm really delighted to be here. I get the easy part. Dr. Tanette Crosswood gave the thanks. I get to reflect a little bit on how I knew Dan. I'd known him for about 20 years in the college. And over that time, I went from being, as Dr. Tuxton said, one of the young guys to one of the old guys. So I think back on Dan and how much he has meant and how much he has helped. I was going over my notes, Dr. Speers, and I reached out to him because he was president of the college in Portland, Oregon, was transitioning. I was just starting as the treasurer. And we talked about things to do and what we needed to do here. And I had reached out to him. I went back over my notes, my emails, and it was on a Sunday, so I agree he worked all the time. I sent him an email on a Sunday back in 2019 because I wanted to go to Morehouse to talk a little bit about a program that we have at Otsuka. And 4 minutes later, I got a reply from Dan. And that was sort of emblematic of how he would work. And we have a program. It's in conjunction with the College of Preventive Medicine. We set it up in 2013. We've had about 25 preventive medicine residents come through the program. And of that, we've had about 70% of people of color. More than half of them have been physicians from the underrepresented groups, blacks and Hispanics. And this is a program set up with Otsuka. And you talked about, I heard Dr. Maybank talk about Dr. Camara Jones. And I stand before you as an immigrant to this country. I stand before you as somebody from Guyana. Stand before you as somebody who's Muslim. And all of those are things that you may look at as not the ideal person or people who have all the advantages. But I was fortunate. I went to the City College of New York, the Sophie Davis School of Biomedical Education, and that was opportunity. And I had professors like Dr. Camara Phyllis Jones. She was one of my teachers. And people like Dr. Jack Geiger. And there were others who afforded me opportunity. And I'm fortunate to be able to work at a place like Otsuka that affords us opportunities to do things that are different and creative, and affords us the opportunity to start things like the pharmacovigilance physician program that brings more than 24 people over the last 7 years into the pharmaceutical industry, opportunities that they may not have had. And this is where, when I hear the word allyship, it's where we have to count on others who have that ability to help to bridge these gaps, or to, as we've heard over and over today, to take action. It is good to hear about the theory and to learn about things, but in the end, it is taking action to meet unmet needs and providing opportunity for people who may not have those opportunities. And so, as a part of the Otsuka group, I was fortunate to have our chief medical officer and our DEI lead officer. And I'd like to ask them just to come up for a few minutes, just to share what it is that we are doing and what other opportunities may exist. And we would look to schools of public health. There is a Dean Lashniak here. There are folks who are in other places. And we want to expand what it is that we're doing to provide opportunities for people to be able to take advantage, so we can bridge the gaps and meet those unmet needs as we move forward. Can I introduce Dr. Christoph Koenen, our Chief Medical Officer? Christoph.
Thank you, Mirza. And I have to say I'm thrilled to have the opportunity of working with the incoming president of the American College of Preventive Medicine every single day. It's a pleasure. We heard a lot about equity in healthcare. And as a pharmaceutical company, our main contribution to healthcare is obviously develop innovative solutions for people with certain diseases. In our case, it's mental wellness as well as nephrology. One way we do this, of course, is we have to produce data. We heard a lot about the importance of data, and that's a very critical part. But when I go back and look at what is the data we really generate, the data is supposed to show that whatever we test is safe as well as efficacious. But it's actually supposed to be safe and efficacious in the population that in the end needs the treatment. But it's not really. Now, to some extent, when you look back at the history of clinical research, you could say it's racist, it's sexist, it's homophobic, and you name, like it is all of it. And that is actually something that we think is extremely important to change. And that takes a lot of work to do because there's a lot of people that we need to convince to trust us as a member of the healthcare community with their data, with their information, with their hard work. Because there's a lot of people in the healthcare systems that do not trust us, and rightfully so. So what we are embarking to do in Otsuka is that we build this trust by starting to work with healthcare providers in different communities, in different locations, that have a different background than our usual investigators that we have worked with. Another way we're doing that is by attracting people into our organization that specifically do not look like me, that look very, very different, because that is another way for us to gain this trust in the community that everyone is willing to work with us. The first step, of course, of doing this is to understand where are we? And we've just went through this process of establishing this baseline. And while there are certain areas where I could probably say, well, we're probably not even that bad, but there's not a single area where I would say we're really good. So based on that baseline, based on the population that is reflected in our clinical trial, the investigators that participate in our clinical trials, I do know that there's a lot of work to do. I do, however, think, and I know Otsuka thinks, that this is very important work, because only if we can show that in the population that we want to treat, our products are safe and efficacious, can we really, truly contribute to equity in healthcare. And now I would like to invite Sabrina to share a little bit broader what we're doing in Otsuka around DE&I.
Thank you, Christoph. Because we are doing a lot of work as it relates to diversity, equity, and inclusion in our clinical trials. But it's a much bigger picture. And it's not as simple as it has been said many times this afternoon. But I always start when people, first when I say I work for Otsuka, they're like, who? I'm like, it's the biggest company you've never heard of. And Otsuka has a long track record of driving innovation through diversity of thought. And in many ways, diversity, equity, and inclusion are inherent in our core values. But the tragic events of 2020 exposed many of the oppressive systems that afflict huge cross-sections of society. And it became very clear to Otsuka that DE&I needed to be a top priority. Otsuka committed to formalizing our approach and building strong structures and processes that would support diversity, equity, and inclusion practices in our culture and beyond. Our vision is to innovate through diverse experiences, embrace unique contributions to create health advancements that lead to equal access and better outcomes for Otsuka people, for the patients we serve, and the communities where we operate. Again, this is not simple, but Otsuka's commitment and investment in advancing underrepresented groups is a human imperative as well as a business imperative. Our DE&I strategy is consistently evolving. We're growing and learning. We look at our progress and we evaluate our results so we can broaden our contribution and our collaboration and extend our reach and set bigger and more impactful goals for each iteration. We began by establishing a DE&I council, which is made up of our senior-most leaders, our CEO, Kabir Nath, our Chief Operating Officer, Christoph Koenen, our Vice President of Human Resources, Andrew Maloney, one of our board members, Bill Carson, and myself. And in addition to that, we have a DE&I round table where we have ambassadors from across the company that step up to contribute and to lead the change. We have employee resource groups. Otsuka funded the B1, which is the Black Employee Otsuka Network for Engagement, which is it was the first Black ERG established at Otsuka, as well as the network of Otsuka women, also known as NOW. We've implemented mandatory unconscious bias training, and we didn't stop there. We followed it up by having education and ongoing communications to reinforce the learnings. We opened dialogue up between colleagues at all levels of the organization to talk openly about their experiences, challenges, unique points of view with programs like manager meetups, leader chats, and the Outside In speaker series where we actually bring people in and we learn from them. And during Black History Month, our ERG B1 collaborated with Daniel Dawes from the Satcher Leadership Institute. And we had a book discussion on his book, The Political Determinants of Health. And we engaged external experts to come in and to audit our talent processes. With that data, we improved our interviewing and hiring practices. And from interviewers to people managers, we're equipping our colleagues to really bring their best, most inclusive selves to each interaction when we're looking to bring diverse talent into the organization. For example, next week, we'll be participating in the Pathways to Success in Biopharma, which is a collaboration of the Trade Association Pharma, the United Negro College Fund, and the Center for Health Innovation. And we'll actually be participating with other companies, having a career booth. And in addition, we have one of our own, Dr. Charlotte Jones-Burton. Are you still here? She is the, not only is she a vice president at Otsuka in our clinical organization, but she's the co-founder of the Women of Color in Pharma organization. And she will be participating in that as well, giving graduates and postdoctoral students from historically Black colleges and universities information about how to enter and to learn about the pharmaceutical industry and learn about the myriad of careers that are available in the industry. And we recently stood up the Otsuka Diversity, Equity, and Inclusion Office to centralize all of our efforts and to extend the reach of our programs. And we've come a long way in the past year, but we're inspired by dedicated professionals like Dr. Blumenthal. With hope and perseverance, Otsuka will continue to forge a path to health equity, replacing disparity with inclusion. We also look for collaborations with other leaders in the field, and we're currently sponsoring a Health Burdens of Inequities report with the Satcher Leadership Institute and Daniel Dawes. So again, it extends far beyond just the clinical research studies that we conduct. From our people to our suppliers, our patients, and communities, Otsuka rallies around those who face adversity. We place greater value on what we can achieve together than what we can do alone, because the needs of those we serve come first, and those we serve are patients. It's been a pleasure gathering with you all today, and I thank everyone for coming, and I thank ACPM and Dr. Rahman for this opportunity, and thank you all for allowing Otsuka to be a part of this wonderful event. And now I'll get out of the way so you all can join us for a reception.
That concludes the program. I want to say thank you again to the ACPM staff. Thank you, Dr. Rahman and Otsuka, for your sponsorship of the reception. Thank you, Dr. Tuckson, the amazing panel, and Dr. Krause-Wood and Dr. Zaza for your leadership of the college. We so appreciate it. The reception is right next door, so please, I don't want to stand between anyone, so please, through these doors or through these doors right here. We'll look forward to gathering with you all. Thank you so much.